Say hey.
Drone, yeah.
Oh, good. Can I get your autograph?
Okay, so if I had a patient with me, first thing I'm going to ask is, what is there anything we're going to be working on today? Anything you want me to focus on during the treatment for you personally?
Oh.
Like, is your back bothering you? Is your neck? Do you have wrist stuff going on? Anything in particular?
I don't care.
Okay, is there any area that's been bothering you more than others?
Maybe my right neck.
Right
Student
neck,
syndrome.
Right shoulder.
Yeah, this
Like
right here.
this.
Okay. So the reason I would ask that at first is because that would be the area I'm going to focus on, right, at some point. And if I'm going to do any muscle testing, that's where I want to check and see what things going on. Are you cool if we do a little muscle testing there first? Okay. So to start with, what I'm going to have you do is bring your chin towards your chest. Hold it there. Don't let me bring you back. I want you to be as strong as you can. That's locked. Can you look up towards the ceiling? Any pain there?
No.
Hold it. That's locked. And you look to your right. Anything? Hold.
Ooh.
Just a little, not much. Rotation's usually not super strong. Hey, another way. Let me know if anything's bothering you when you do the motions. A little stronger that way. Ear to shoulder, either way. Hold there. Starting to beat a little bit, and ear to shoulder, hold there.
Not hurt here.
Felt that on that side, okay. Can you bring your arms up like you're doing the C5 muscle test? Or the C5, yeah, deltoid there. Hold. Aha!
Ooh.
There we go. Now we're starting to find something. And then the Super Mario punching. Neutral fist. Hold that, don't leave push it down. The other side. Hold. And wait, one more. Hold.
Aw, show off.
So at some point, I'll definitely make sure to focus on anterior deltoid, middle delt, or supraspinatus for that outer strap on the right, anterior delt on both sides. You all are students, so anterior delts, like everyone. And then we had weakness a little bit with the right rotation and the left lateral flexion, I think. Not the right, maybe the right too a little bit. If
Left
we have
more
weakness
than
or
right.
rotation, things that I'm going to be thinking about checking are going to be the levator scap on that side and the contralateral SCM and the contralateral trap, technically. Okay, so with a patient that I'm going to do a general kind of wellness screen with, like let's say you came into me and kind of like you said when you first started, you're just like, I just wanted you to kind of check it out, I'm tight areas and I'm
So
sore
c'est la
areas,
vie.
and I don't know, I got stuff in my knees, my shoulders, whatever. I just kind of want you to do it like a tune-up, right? Like a more of a wellness visit. So what I have you do is start face down. And the general flow I follow varies a little bit depending on how much time I have with the patient, as well as just in general what they're dealing with. But the first thing I like to start with is starting with the hamstring. I used to start by doing this kind of fascial splaying motion. So you could even start here too with one hand on like the contralateral like lat fascia plane there, and the other hand on the hamstring on the ipsilateral side. And you're just kind of like opening up the fascia of the back, and then I can switch sides and kind of open up the fascia this way. Then what I like to do is, the first move I usually do though, is I walk with my palms down the hamstring, so I'm getting that perpendicular pressure into the hamstring. I squeeze the calf muscles gently, hopefully it's not too uncomfortable. And I can pop your shoes off too real quick. When I first started, I used to have some patients that would leave their shoes on and they just wouldn't work on their feet or touch their feet. And then now I have literally every patient take their shoes off because I find the feet have pretty much everything they're dealing with. There's something in the foot that's related to it. So anyway, back where we were. Squeezing the calf on my way down, and then I grab the foot, traction kind of down, use my hand as a fulcrum, bend, get a little stretch in the quad. I might even curl the toes a little bit and rock back and forth like so. After that, I'm going to go after the GTOs of calf, of gastroc. So my thumb is going deep pressure into the back of the femur on the insertion point. And then I'm going to do the opposite, the lateral head, going onto the lateral femur. So I'm just nudging in there. That's where I'm feeling a lot of tone. So I'm just nudge. I'm going to try to use my body to describe what I'm doing with my hand so you can really see it, but it's like nudge, nudge, hold, keeping the foot flexed because it allows me to like keep more slack in the muscle and not have it super tight. Then I'm gonna walk down that hamstring again, and I'm gonna take my fingers and kind of piano fingers into the pes anserinus and feel the tendon of the medial hamstring going into the pes anserinus. Then with knuckles, nudge up into the ish tube, up into the ish tube now for the lateral hamstring, and now work my way down that. And then I push with my thumb back into the fibular head. So now I've hit hamstring and calf from both angles. I didn't mention this, but you can also do your calf here, squeeze around the ankle by putting pressure kind of up and into those tendons of the calf. Now, I wouldn't normally do this, but just for fun, hold your leg here. Don't let me push it down. Now that should really lock. This side we haven't worked on, and I'm guessing because it was tight over there, this was probably tight too. Hold there, don't let me push you down. And there it goes. So, then we switch sides. I might, after I do this, sometimes I think of the leg as like this chunk with the hip. Sometimes I think of it as I'm gonna do here, here, then hip, and then switch to this hip. In that case, I'm gonna do that instead of going to both of those right away. Also, because if it's a new patient, I don't want to immediately start contacting the glutes. I like to start with like the legs or something, get them comfortable with my hands, what everything feels like, what the pressure feels like. Keep in mind with a lot of patients, you're going to be asking them, let me know if there's anything too much pressure, anything's hurting you. Like there, I saw a flinch, so I'm going to back off a little bit because I don't want my patient to fight me. Instead, I want to feel, kind of see the leg went a little more limp there. I want to feel that tone. Just decompress. So.
When you're charting afterwards, do you chart as you usually would, like for those flinches and for the tone of the muscles with the muscle grading?
In my chart, I have a section for spasm, which I will mark as either mild, moderate, or severe in different muscles. I have a little diagram I draw on where I'll discuss, like I'll draw and put points where I found like the most. So say it was like right behind the knee for like gastrocs insertion, I'll draw that on my little picture I have on my chart and make a little note that that insertion point was the most tender, and had like a spasm-like response. Like you could chart like you do here, like the +3 or +2, and then I also would mark the muscle test weakness, and I would also mark range of motion too. So I didn't show range of motion, but I would have done range of motion with anything I'm going to be treating the patient before I do this. So I'm just going through it. I don't know if you saw any of that, but I just did the same thing on the side. Now moving into the glute. So I like to start with a palm into the side of the sacrum, kind of nudging along glute max's insertions, so like so, as I work my way up and around it. And then I'm moving into glute med. So at some point it crosses over and you get more into glute med. I kind of use my palm a little bit, and then I might follow up more with like fingers, where I'm walking my thumbs, keeping this upward angle of pressure into the origin of glute med. And right through here, I definitely can feel some gnarly tone jumping out at me. So I'm going to nudge into that a little bit, and then sometimes if I feel like it, and I want to get more of like a broad, firm pressure, I'll switch to my elbow here, and I'll nudge kind of like in and up, like so. So I'm really getting like upward pressure, and notice like the angle of my body now. I can use my body mechanics to help me. I also treat on a much higher table in general. So if you have a table that elevates, you could be doing a lot of this work with it way up high, so you're not in such a weird position like I am now. So nudging up into glute med's insertion there. Then I'm going to switch, and first I'm actually going to press into the femur and slightly down, but mainly in below the greater trochanter, because glute max has that insertion along the lateral femur there. It's a big firm tendon, or a big long like sheet of paper tendon, if you remember from Cadaver Lab. And I think it was Mahdi, he was like an orthopedic surgeon that went through this program a little bit ago. He was telling me that when they used to do surgery on hips or anything and they cut that tendon, it was like a big sheet of paper they're cutting. It's a huge insertion. So don't think of glute max as just IT band. It has a big chunk going into the femur there. So I press into that, then I switch and I push into the top of the greater trochanter. This is going to get those glute med insertions, piriformis, some of those rotators, and if you look at her foot, you can see it moving as I press into internal rotation because I'm pushing down, but I can also push inferiorly as well and get some of that glute med hooking into the top of the greater trochanter. After I've worked with my thenar a little bit there, then I switch to my thumbs. I kind of go in a little bit, like, and then down. So I can get right onto the top of that greater trochanter and start searching like right here. I feel a really, really toned up tendinous insertion point that I'm just gonna go nudge, nudge. Oh, yeah, and there's a little flinch. It's a little tender there. And hold. I used to always be like very verbal with my patients. Tell me this hurt, blah, 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 blah. As I've gotten more comfortable with like how much pressure I'm using and how gentle I am and kind of when to use more pressure, when not to, I just go kind of off that. Now, if the patient really flinches and pulls away, I know it was too much, but I always preface before I treat a patient and say, let me know if it's ever too much for you, I can always back off. But I find as you keep treating, you'll get more comfortable with feeling and tuning into the patient. Pushing really in like this for that glute med or glute max insertion into the femur. It's really kind of a flat palm straight in. If you wanted to switch to your thumbs and kind of walk into it like this, you could also do that. Then I'm going to work my way along that glute med up into the corner here. I might switch to my elbow. This is kind of a fun move. You can use a palm on your other hand. So now you're using your elbow almost as like a unit. You're not just pushing with your shoulder. You can actually use your other hand kind of nudging. Oh yeah. Should have muscle tested hip abduction, baby hip. So with a wellness patient, I'm going to be muscle testing all the areas I'm treating to justify treating that area, doing a full history, as you all